Jessica Donington was going to come and her flight got canceled yesterday, so she wasn't actually able to make it in time for the meeting. So there's 2 studies from NRG that she wanted us to present. I have to be honest, I don't know anything about this one and just looked at the slides like 5 minutes before we came in, but we'll do our best here to walk through it. And then the other one, of course, is the oligometastatic disease study, of which Steve Swisher has been one of the driving forces on, so he's going to talk about that one briefly. So let's see what we have here. So this is a study that I think a pilot version is already being done in Canada right now with the McMaster group, Yaron Shargal and John Oxarian and others, looking at the role of neoadjuvant SBRT for larger tumors. So the rationale for this is that, again, optimal therapy unclear, complete resection appears to be essential for cure. And the study is basically asking the question of whether or not we might be able to do a better job if we use combined local therapy of neoadjuvant SBRT followed by resection. There was apparently somebody had a paper, I guess, that was the backdrop for all of this. Again, Jess knows all the details, but there is at least some pilot data suggesting that this is possible and feasible. I have to be honest, I don't know what that means. But in terms of what's been done to date here, certainly on the pilot study, they've got 6 patients enrolled on study with a 40 gray total SBRT dose that the patients have subsequently gone on and had operation done successfully. And I think the reason Jess absolutely wanted to get some feedback on this is that apparently the concept is bubbling up through NRG, and clearly it would take pretty significant surgical buy-in from people if this was really going to mature and be something that got submitted to CTEP. So what she really wanted was a pulse of the room as to whether or not people thought this is a non-starter, whether there's some interest, whether or not we'd actually be enthusiastic about it, whether it made sense. While you're pondering that, I can tell you a similar version to this, what Rob Merritt had presented at the Alliance about a year ago. It wasn't for larger tumors, but it was for stage 1 and stage 2 lesions. And I'm not really sure why. Both Linda and I were moderately enthusiastic about the idea, and our radiation oncologists in the Alliance just jumped all over it and trashed it, which didn't completely make sense to me, but they seem somewhat offended even by the idea. This is a little bit different in terms of it being for bigger tumors. Let me just go back to the... Yeah, here. So this would be for T3, T4, N0, or N1, M0 tumors. Again, with the idea of using SBRT as neoadjuvant therapy followed by surgical resection. Royce.
Is the hope that it'll elicit some sort of antigen expression, immune response? Otherwise, why not just take it out?
That's an interesting idea of let's say radiating first and then using an IO, but I don't think that's baked into this, from what I understand. Brian?
Yeah, I remember that there was, I think seeds of this were kicking around the Alliance when the Alliance was, formed from its antecedent groups. I've even forgotten now what they were. But there was a paper, I think, out of Boston Medical Center that was a retrospective case series, personal surgeon's experience, where induction therapy was used routinely in patients with chest wall tumors, and not pancreas, they're non-pancreas chest wall tumors. Mm-hmm. And the outcomes were then compared with either patients at the same center that had a different strategy by different surgeons, or historic controls that are reported elsewhere for chest wall tumors, non-pancreas chest wall tumors. And there was a signal that this induction strategy was better. And that it was brought up, this is something that we could study, and at that time there was really no money for trials and no enthusiasm amongst the medical oncologists and radiation oncologists, and so it just basically got shelved. And I think that the SBRT is just trying to put a little modern window dressing on and try again, like to put it through. And I think that when you have a kind of an isolated paper that seems really favorable, that is a good impetus to try to study something in a little bit more prospective way and see if other centers can evoke the same results. And I think, as it was said earlier this morning, that induction therapy is tolerated a lot better than adjuvant therapy. You have a patient who hasn't had any complications yet, and so theoretically, this seems like a interesting and useful strategy.
So to put you on the spot, would you guys do this?
Yeah, we do that.
Okay. Steve?
I'm not sure about this. I mean, I think the more interesting question is the stuff that's brought up from the Pacific trial with stage 3 disease, where they did chemoradiation versus chemoradiation and then darvolutamab for a year. And to me, this is just kind of, I'm not sure if this question is as interesting. I mean, it would be more interesting to me if you're trying a novel thing where you keep surgery in the local regional armamentarium, but you're adding immuno on the end and see if there's a big jump. Because we got to start looking at new schemes where surgery somehow is involved with immunotherapy. So maybe that would make it more interesting.
Mm-hmm. So just to be clear, having a immunotherapy versus not, let's say, tagged on the end of something like this.
Yeah, this is a single arm study.
Yeah, what's being done right now in the pilot,
right.
yes.
So it's kind of just a test, right? And you're trying to see if you get a big jump, I guess, right? So, I mean, I would just add on the backside, like the Pacific trial did, immunotherapy, because these patients are high risk, right?
Mm-hmm.
And so, but I'm not sure how you would say it made it in advance. How are they going to know this is made it in advance?
Yeah, not sure.
So, yeah, I mean, that's the problem with this study a little bit. At the end of the day, what's our end point to say that this is better than what we did before?
Other feedback. I think Jess is going to be here later today or tomorrow, so if you see her in the hallway, don't hesitate to ask her about the study. Okay.